Many of you know Michelle. She's one of my partners. She's the medical director of our Colorado Sports Center in Denver. She trained with some of my colleagues in Iowa in sports medicine with sort of an emphasis on foot and ankle. So I'm going to ask her to come up and speak about chronic exertional compartment syndrome in the athlete, something we all need to be aware of and familiar with. So Michelle, welcome up.
All right, so now I have some experience with this pointer. So I'm going to do this more as a case-based approach, because one of the things that I get a lot of people that are referred to me for leg pain in a running athlete. And I don't know if anything terrifies orthopedic surgeons more than leg pain in a running athlete, because they're like, yeah, you're running, and I'm sure that hurts because you run long distances. But that being said, I am a runner, and so I feel a little bit more personal attachment to this kind of a topic. We'll go through a couple of different things that this can present as, but chronic exertional compartment syndrome being the one that I tend to do surgery on the most. So in this case, this is a 17-year-old college soccer player. She's had pain in both of her legs during and after playing soccer and running, but she's had symptoms off and on for about 3 years. So first thing I always think about, is this something metabolic? Usually with a female athlete, oftentimes in a teenager. This is a 17-year-old, so although she's in college, she's still fairly young. Could this be something related to just her nutrition? Could this be related to hormonal imbalances? Could this be related to, especially here in Colorado, having iron deficiency or low hemoglobin, hematocrit, et cetera? So that's one thing I'll talk to them about to start with. So we talk a little bit about, and I interview them about their nutrition, about what they eat, about how they feel in terms of fatigue, other issues, whether or not they take recovery workouts, and that's how I term it, because a lot of these athletes won't take a day to recover, but if you term it a workout, then it becomes a part of the process and a part of their plan. They'll buy into that a little bit more. And then I think you need to really also talk to them in counseling about what they're doing, whether or not they're overusing things, et cetera, because especially with a running athlete, their identity is, and with almost any athlete, their identity is pretty wrapped up in these activities. So she presented, she'd been playing soccer for most of her life. She had menarche at age 14, which is relevant particularly in some of these younger athletes. She plays or practices 5 days a week, so there's not much time for recovery, but even on her recovery days, she does strength and conditioning workouts. She has a history of stress fractures, so she has leg pain. She has a history of stress fractures, so that's at least something we're going to look at. She has symptoms running any more than about 10 minutes. She stops running because it hurts, meaning that she can't continue to run through it at certain points. She describes her pain being primarily in the front of her leg. She describes it sometimes as feeling tight. Sometimes she'll have a symptom that feels like she's slapping her foot down. She can occasionally have numbness in the front of her foot or on the top of her foot, and it does get better and after a few minutes of rest. So we certainly look for stress fractures in this athlete who had a history of them. These are more characterized by pain during activity and also after activity. I've myself had some, and I can tell you that it doesn't always hurt when you're running. Sometimes it hurts after you're running, so that isn't a clear symptom. It's very specific, though, if it's a stress fracture versus maybe a stress reaction. Usually they can point to exactly where it hurts with one finger or a general zone that's only a couple centimeters long. It might be accompanied by swelling, particularly in some of the more chronic or superficial areas, such as the leg. I would just say a couple of things about stress fractures. It's either abnormal stress in normal bone or normal stress in abnormal bone. And most of these athletes, it's abnormal stress in normal bone. But that goes back to some of these metabolic issues. It could be abnormal bone. I wouldn't say any of them would be defined as normal stress in that situation, though. X-rays, I think, are always helpful. I will always get X-rays in leg pain in a runner. I've found more stress fractures this way that were not known to be stress fractures. In fact, very recently, had a woman who's a rugby athlete who had a pretty profound callus in her proximal tibia from chronic repetitive stress fractures. She had no idea, and she continued to play and run. And in rugby, I'm certainly worried about contact there, so probably hopefully avoiding a disaster. MRI can be helpful in some that maybe where you don't see that callus or you don't feel that palpable swelling or it doesn't seem to be very point specific. These are a couple of examples of things you can see on an MRI, whether you actually see a crack, but you certainly see the edema surrounding it and edema here. This can sometimes be the result of finding a stress fracture, particularly in a chronic situation, and particularly where you have this non-healing chronic, we call the dreaded black line, but that shows you it's on the tension side of the bone and is not going to heal with just cessation of activity or stress. But this is the one that I probably see the most and gets referred to me the most, because these are a little bit challenging sometimes to figure out. This is really characterized by most of the symptoms that she came in with. So she had pain over a muscle instead of over bone. It gets worse with time and decreases with rest. They usually describe it somehow as cramping or tightness, occasionally as a burning. Certainly you can have them describe it with some of the nerve symptoms such as numbness or slapping feet, which is really more of a weakness, but it can also just be fatigue of that compartment when the muscle's under that stress or pressure. So I do get general blood work on this. I usually get a metabolic workup to look at some of those things we talked about before. I think you can have iron levels that are normal, but probably aren't normal in an athlete that's doing as much as some of these athletes are doing. So if they're low normal, I'll still supplement that. I think we want to look at, again, some of the other things like B12 that can cause neuropathic symptoms, neuropathic symptoms, but just general leg pain, cramping, electrolytes, hematocrit, things like that. So I do get those typically in almost anyone who hasn't had any further workup. But if they have symptoms that are very consistent and can reproduce them, then we'll test them. And I can test them in the clinic. We do test them up here in Boulder and down at our Denver clinic, but not everyone has a setup to test these. Essentially, it requires the use of this compartment pressure monitor striker device. Makes this. I'm unaware of anybody else who makes one. But the standard way of testing this is you test the pressures by putting this rather wide diameter needle, hollow needle, into the compartment, push some fluid into that, and measure the pressure coming back. And so when you do that in the compartments of the leg, there are 4 compartments, we'll show those in a minute. You test all 4 compartments. The textbook way of doing that is to do that at rest, to do that immediately following exercise, or for me, I have them exercise until they have kind of their maximum symptoms, and then 5 minutes post-exercise so you can see that that pressure resolves. But it requires the specific equipment, and I don't usually do this 3 times. I think if you really want to do this and use this equipment, you really need to use 3 different setups for it because it's not really sterile after every time you do it, which can be a bit expensive. But I also think it's not very pleasant for the patient. This needle's kind of big, and you poke them, in 4 compartments 3 times. So I've gone from doing that. I generally don't do it that way, but rather just immediately after exercise. The treatment for exertional compartment syndrome is a little bit, I don't want to say controversial. I don't think it's necessarily controversial. Certainly I think it's always worth trying the conservative treatment and options here, but they're rarely successful. And that's been borne out in multiple studies. I'll take a minute and talk about this Botox injection thing because it's been relatively new. And people ask me about it pretty frequently. In investigating this a little bit further, what is happening in these injections is they're basically trying to relax muscle, which sort of makes sense. And there's a specific slip of muscle, which I'll show a little bit later here, that can compress the popliteal artery. So I don't think this is necessarily really a treatment for compartment syndrome. But surgical release of the compartments is really sort of the gold standard. It's fasciotomies like we would do in a trauma situation. It's not a trauma situation, so we can try to make those look a little bit more cosmetic. This is the analogy I said earlier. I like analogies. This is my analogy. It's like a hot dog. Put it in the microwave, it explodes. It doesn't explode. Their leg's not going to explode, but you want to basically release that pressure. So when that swelling occurs, that can accommodate that swelling. And I tell them to put a fork in it. So here are the compartments, the main 4 compartments of the leg. You have the anterior compartment, the lateral compartment, the deep posterior compartment, and the superficial posterior compartment. By far the majority of these are occurring, are occurring in these anterior and lateral compartments. Anterior most common, lateral very commonly. For me, I think if I'm going to do a compartment release of the anterior compartment, I'm going to do a compartment release of the lateral at the same time. It's no different morbidity, no different recovery. It's really almost no different surgery. But I've had a couple of people, and the reason I started doing this, where I would release the anterior compartment, and they're like, great, now I can run again. They'd run further and later develop symptoms in their lateral compartment. So I release them both. This is a more typical example of the kinds of incisions. I use a small distal incision here to find the superficial perineal nerve as it's coming up through here, and then usually a proximal incision just so that I can make sure the fasciotomy is from the distal portion of the compartment all the way up to the proximal compartment. If you leave any gaps in this, you essentially create hernias, which can be as painful as the exertional compartment syndrome itself. This is just a brief word about popliteal artery entrapment syndrome. This is generally thought to be this abnormal slip, usually off of the soleus, but a slip of muscle here that can kind of compress the popliteal artery. Symptoms of this are going to be more posterior calf kinds of cramping. It is, in essence, sort of a vascular claudication type of symptom in an otherwise young, healthy person. And it's difficult to kind of find these. You need to have a radiologist that can see it or that knows what to look for, because it's easy to miss it. But an MRI is really the best way to see it. And if you inject it and paralyze this muscle, you may affect some relief of those symptoms. And I think that's maybe where this Botox thing has been used a little bit more effectively. I do also want to talk for a minute about medial tibial stress syndrome, which is not very common but does occasionally occur and can get confused with stress fractures or shin splints or exertional compartment syndrome because it occurs in a similar area. But it's essentially right along the posterior medial border of the tibia where these muscle groups are attaching, and it's repetitive stress or inflammation or scarring of the periosteum where that muscle is attaching. The thickest area is really where the soleus comes in, so you'll see it in a very distinct area, most often in that kind of distal third area in the tibia, although it can be pretty broad. Treatment for this actually is more effective than surgery. Is rest. It could be an early symptom of a stress fracture, so I think that rest component is important. Orthotics can be helpful because of the way we talked about that heel alignment in some of the previous talks. It can certainly pull on that medial tibia. Physical therapy and some deep tissue and muscle release techniques that some of you guys do. Shoe wear, running surface can be helpful. But if none of those things work, very rarely we'll end up doing surgery on this. And I basically just remove the scarred or inflamed tissue along that periosteum. I have been doing some of these with my colleagues, with Dr. Hill in the Denver clinic, of injecting that area with lidocaine and having them run, just to be sure that's actually the diagnosis. If they don't have pain in the periosteum right in that area when they run, then I'm pretty certain that that's where their pain is coming from, and those are the ones that I'll counsel about surgery. So in conclusion, I think when you have leg pain in a runner, especially lower leg pain, you need to think about multiple issues, not just exertional compartment syndrome, but these metabolic issues, popliteal artery entrapment, stress fractures, exertional compartment syndrome, and medial tibial stress syndrome. So that was a very quick summary of leg pain in runners.